A 35-year-old woman presents with severe dysmenorrhea, heavy menstrual bleeding, and a history of infertility. On physical examination, you note a tender, fixed pelvic mass. Pelvic ultrasound shows a 7 cm left adnexal mass. What is the most appropriate next step in management? A. Hormonal therapy with oral contraceptives. B. Ultrasound-guided drainage of the adnexal mass. C. Immediate laparoscopy for surgical removal of the mass. D. Start empiric antibiotics for possible pelvic inflammatory disease, PID. Answer C. Immediate laparoscopy for surgical removal of the mass. This scenario is concerning for an ovarian endometrioma, a type of endometriosis that can cause severe pain and infertility. Given the size of the mass and the symptoms, surgical intervention with laparoscopy for removal of the endometrioma is the most appropriate management. Hormonal therapy may provide some relief but is not curative. Ultrasound-guided drainage would not address the underlying problem, and empiric antibiotics are not indicated in the absence of signs of infection. A 28-year-old sexually active woman presents with lower abdominal pain and foul-smelling vaginal discharge. On pelvic examination, you observe cervical motion tenderness and purulent cervical discharge. A wet mount of vaginal secretions reveals motile, flagellated organisms. What is the most appropriate treatment for this patient? A. Metronidazole. B. Doxycycline. C. Ceftriaxone. D. Azithromycin. Answer A. Metronidazole. This scenario is suggestive of trichomoniasis, a sexually transmitted infection caused by the protozoan parasite Trichomonas vaginalis. The treatment of choice for trichomoniasis is metronidazole. Doxycycline, ceftriaxone, and azithromycin are used to treat other sexually transmitted infections like chlamydia and gonorrhea. A 45-year-old woman presents with postmenopausal bleeding. On pelvic ultrasound, an endometrial thickness of 12 mm is noted. Endometrial biopsy reveals complex hyperplasia with atypia. What is the most appropriate next step in management? A. Hysterectomy. B. Progestin therapy. C. Repeat endometrial biopsy in 6 months. D. Observation. Answer A. Hysterectomy. This patient has complex hyperplasia with atypia, a precancerous condition of the endometrium. The management of choice is hysterectomy, as it provides definitive treatment and prevents progression to endometrial cancer. Progestin therapy is an option for patients who wish to preserve fertility but is less appropriate in the presence of atypia. Repeat biopsy or observation are not recommended for patients with atypical hyperplasia. A 30-year-old woman presents with a 3-month history of irregular, heavy menstrual bleeding and pelvic pain. Transvaginal ultrasound reveals multiple uterine fibroids, with the largest measuring 8 cm. She desires future fertility. What is the most appropriate initial management for this patient? A. Myomectomy. B. Hysterectomy. C. Hormonal therapy. D. Uterine artery embolization. Answer C. Hormonal therapy for a young patient with uterine fibroids who desires future fertility. Initial management often involves hormonal therapy to control symptoms. Hormonal therapy may include oral contraceptives, progestins, or gonadotropin-releasing hormone (GnRH) agonists. Myomectomy is a surgical option if fertility preservation is a priority, and hysterectomy is considered if fertility is not a concern or if conservative treatments fail. Uterine artery embolization is another option but is typically reserved for patients who are not candidates for surgery. A 28-year-old nulliparous woman presents with severe pelvic pain and missed periods for the past 6 weeks. A urine pregnancy test is positive. Transvaginal ultrasound reveals an ectopic pregnancy with a heartbeat. What is the most appropriate treatment for this patient? A. Expectant management. B. Laparoscopic salpingostomy. C. Methotrexate therapy. D. Immediate laparotomy. Answer B. Laparoscopic salpingostomy. In the case of a viable ectopic pregnancy, laparoscopic salpingostomy is often the preferred treatment option. This procedure preserves the fallopian tube and allows for future fertility. Methotrexate therapy, choice C, can be considered in some cases, but it is typically reserved for unruptured or non-viable ectopic pregnancies. Expectant management, choice A, is not appropriate in the presence of a viable ectopic pregnancy, and immediate laparotomy, choice D, is usually reserved for emergencies with severe hemorrhage or instability. A 20-year-old sexually active woman presents with lower abdominal pain and vaginal bleeding. She has a positive pregnancy test and reports a history of an intrauterine device, IUD, for contraception. On pelvic ultrasound, you observe a gestational sac located outside the uterine cavity. What is the most appropriate management for this patient? A. Administer methotrexate. B. Immediate surgical removal of the ectopic pregnancy. C. Remove the IUD and monitor closely. D. Prescribe antibiotics for pelvic inflammatory disease, PID. Answer B. Immediate surgical removal of the ectopic pregnancy. This patient has an ectopic pregnancy, and it poses a significant risk to her health. Immediate surgical removal of the ectopic pregnancy is indicated to prevent rupture and hemorrhage. Methotrexate, choice A, is an option for selected patients with ectopic pregnancies, but in the presence of acute symptoms or a high-risk scenario, surgical intervention is preferred. Removing the IUD, choice C, is not the primary treatment for an ectopic pregnancy. Antibiotics for PID, choice D, are not indicated without evidence of infection. A 32-year-old woman presents with a 6-month history of cyclic pelvic pain, dysmenorrhea, and deep dyspareunia. On pelvic examination, you note tender nodules on the uterosacral ligaments. What is the most appropriate initial management for this patient? A. Empiric treatment with nonsteroidal anti-inflammatory drugs, NSAIDs. B. Laparoscopic excision of endometriosis. C. Hormonal therapy with oral contraceptives. D. Immediate referral for in vitro fertilization, IVF. Answer A. Empiric treatment with nonsteroidal anti-inflammatory drugs, NSAIDs. This patient's presentation is suggestive of endometriosis. Empiric treatment with NSAIDs is a reasonable initial step to relieve pain and inflammation. If symptoms persist or worsen, further evaluation and management may include laparoscopic excision of endometriosis, choice B, or hormonal therapy, choice C. Immediate referral for IVF, choice D, is not typically the first step in managing endometriosis-related pain. A 38-year-old woman with a family history of breast cancer presents for her annual gynecological exam. She has no gynecological symptoms but is concerned about her risk of ovarian cancer. What is the most appropriate management for this patient? A. Offer prophylactic bilateral salpingo-oophorectomy. B. Perform annual CA-125 and transvaginal ultrasound screening. C. Start oral contraceptives for ovarian cancer risk reduction. D. Refer for BRCA gene testing. Answer D. Refer for BRCA gene testing. Given the family history of breast cancer, this patient may have an increased risk of hereditary ovarian cancer. Referring her for BRCA gene testing is the most appropriate next step to assess her risk and determine whether prophylactic surgery or other risk reduction strategies are indicated. Prophylactic bilateral salpingo-oophorectomy, choice A, is considered for individuals with BRCA mutations who have completed childbearing. CA-125 and transvaginal ultrasound screening, choice B, are not recommended for general population screening due to their limited sensitivity and specificity. While oral contraceptives, choice C, can reduce the risk of ovarian cancer, they are not the primary approach for individuals with hereditary risk factors. A 26-year-old nulliparous woman presents with a 3-day history of lower abdominal pain and vaginal bleeding. Her last menstrual period was 6 weeks ago. She has a positive urine pregnancy test. On pelvic examination, she has cervical motion tenderness. What is the most appropriate diagnostic test for this patient? A. Transvaginal ultrasound. B. Serum human chorionic gonadotropin, HCG, measurement. C. Endometrial biopsy. D. Laparoscopy. Answer A. Transvaginal ultrasound. This patient presents with signs of an ectopic pregnancy, and transvaginal ultrasound is the most appropriate diagnostic test to visualize the location of the pregnancy, assess for rupture, and determine the need for further intervention. Serum HCG measurement, choice B, is helpful but is often combined with ultrasound for a comprehensive evaluation. Endometrial biopsy, choice C, is not indicated in the evaluation of ectopic pregnancy. Laparoscopy, choice D, may be necessary if the patient is unstable or if the ultrasound findings are inconclusive, but it is not the initial diagnostic test of choice. A 45-year-old woman presents with a 1-year history of heavy menstrual bleeding. She has completed childbearing and desires definitive treatment. Pelvic ultrasound reveals multiple uterine fibroids, and endometrial biopsy is normal. What is the most appropriate management for this patient? A. Oral contraceptives. B. Levonorgestrel-releasing intrauterine device, IUD. C. Uterine artery embolization. D. Hysterectomy. Answer: D. Hysterectomy for a patient with completed childbearing who presents with heavy menstrual bleeding and uterine fibroids and desires definitive treatment. Hysterectomy is often the most appropriate management option. This procedure provides a permanent solution for fibroid-related symptoms. Oral contraceptives, choice A, and levonorgestrel-releasing IUDs, choice B, are typically used for medical management but do not provide a definitive cure. Uterine artery embolization, choice C, is an alternative to surgery but is not considered a definitive treatment in all cases.